Hi everyone, welcome back to the series Life of a Pulmonologist, and we are going to shoot the second episode. In the second episode we have Dr. Jindal SK Jindal sir with us, and we'll be talking about the pulmonology part which was before and which is now. So sir, welcome. My first question to you will be on evolution of pulmonary medicine. So you have been working, sir, since last 40 years, and you have seen a lot of developments, evolution, maybe in terms of therapeutics or diagnostics. So what is the major shift which you have seen in last 40 years?
I think the major shift had appeared in the late 80s and early 90s when pulmonologists all over the country and chest physicians in general started noticing the increasing burden of non-tuberculous respiratory diseases, asthma, chronic bronchitis as well. And tuberculosis, of course, had always remained a very big problem in the country, but somehow everything got confused with tuberculosis because of the overwhelming burden of tuberculosis. So I must say it was roughly late 80s, when in fact we started the postdoctoral DM program in pulmonary medicine, also so as to include non-tubercular lung diseases as also important component of chest therapy, chest diseases, And since then, of course, it has been growing, since it is now being recognized more and more that several new diseases have also appeared, which not only asthma and COPD, interstitial lung diseases, and then of course oncological diseases, pulmonary interventions, and so on.
So my next question was that only, sir. So we started with a lot of tuberculosis in the past, and now we have a lot of diseases of like COPD, ILD, which has come up. So what do you think is the more likely disease or trend that must be coming in the next decades or so?
Yes, I think the tuberculosis, of course, remains one issue, but that is now largely included in the national tuberculosis elimination program. So I think it's not restricted only to chest physicians. It is a problem which is faced by all doctors and the other health personnel. As far as the other lung diseases are concerned, asthma and the COPD remain and continue to in fact increase in numbers, and then interstitial lung diseases are increasing. They more and more causes are being recognized now, and it's not only idiopathic interstitial pneumonias or pulmonary fibrosis, but several other kinds of hypersensitivity diseases and occupational diseases also present as interstitial diseases. So I am sure that we in near future and as well as in distant future will be seeing more diffuse lung diseases.
So talking about the diagnosis, sir, as you mentioned that we came and we are diagnosing more kind of ILDs, and they are not IPFs, we are getting into the causative age subtype of ILD. So all this came because of maybe further investigations which we have right now. So coming from chest X-ray, which was I think the major thing which at your time when you started, and now we have ILD for the diagnosis of ILD, we have CT scans and investigation. So what do you think about it, how it has evolved in front of you, and what do you think the future will be?
Yes, I think as you said, radiology was an important diagnostic investigation for interstitial lung disease, and the invent of high resolution CT scans in particular made a impact, significant impact on the diagnosis. And earlier it was always, people said, taking biopsies and interventions, etc. But largely the advent of HRCT scan made the biopsy and other intervention procedures disappear for diagnosis of most of the ILD conditions, you see. Now, of course, our stress is on even earlier diagnosis and exclusion of other causes of interstitial diseases. And so one is, of course, HRCT scans are being now kind of being done with the help of AI algorithms, kind of larger data, so that the interpretation can be made by the AI programs as well, and it will be very great help to assist the clinicians and the radiologists.
My question will be, are we getting too much dependent on AI? Is it going to take over the clinician's mind?
Well, yes, I think one has to be very cautious about being dependent. AI in every field is a risk, you see, that people start depending on the interpretation. So that has to be used wisely, and with kind of discretion. That is true, you see. So not a kind of blanket diagnosis made by the programs like AI programs, you see. On the other hand, it can assist in interpreting the data. That can be a better interpretation, and then of course the doctor needs to apply his or her mind to the diagnosis, you see, and give a comprehensive view of the patient's condition.
So earlier it was like clinical medicine mostly. Now we have a lot of diagnostics like EBUS. Of course, you talked about AI. So how do we strike a balance between the art of medicine and the recent advancements and technologies we have?
Yeah, I think that the doctors have to be very careful and wise in their decision making. They should not lose their own perspective about the patient, because patient is concerned about his disease, while many times the AI based algorithms as well as other programs, they make one diagnosis, but it is for the doctor to decide whether that fits in with the problems of the patient, because patient is still a human being, you see, and he has his own problems. He is not concerned only with the diagnosis, he is concerned with the complaints, with his problems, you see. And so the doctor has to kind of analyze this data which is available in front of him, you see, and rather not depend on the interpretation made by the
AI.
The AI.
So my next question will be the broad spectrum treatments. So are we going into the customized treatment or the targeted treatment or the broad spectrum treatment? So how it has evolved in last 40 years, according to you, what was there before 40 years, the broad spectrum treatment was there or not, and how we are moving towards the customized treatment or the targeted therapy for the ILD per se, maybe?
Yes, I agree that I think the personalized therapy is important, and there is nothing new about it. In fact, if I can remember our own grandparents saying, you see, that this drug does not suit me, this problem does not, food does not suit me, etc., etc. So that is in a way kind of personalized treatment, you see, or personalized problems, you see. Subsequently came the broad spectrum treatments, you see, which we thought that it should fit all. We all know, for example, that the hypersensitivity reaction can occur in an individual patient. So that is quite personalized, you see. Or the allergic reactions to drugs are also personalized. So similarly, the response to the drugs, even the therapeutic response to the drugs, is a kind of personalized. Basically, the phenotyping, which is becoming more and more popular, is trying to identify the clusters of patients, you see, within the same group of diseases. One group of patients who can behave differently and the other group who behaves differently. So I'm sure that the personalized treatment will be more prevalent in the near future, not only for asthma but also for other conditions. Today we have heard COPD, even lung cancer, for that we know. All types of cancers, they have all kind of treatments based on different characteristics, or even nowadays people are going to identify such responses based on other factors also, the genetic factors including, you see. So it is not only the phenotyping and the endotyping and then genotyping. So the responses are different, and I think in near future we will be seeing the expansion of precision treatment for, or the personalized treatment for most of these conditions. But still the broad principles will remain the same, that we cannot really, because the disease overall, the pathogenesis or mechanisms is the same.
So basically you mean to say that every individual is different and should be treated?
Yes, in a way, at least some group of patient may respond, every individual may respond differently, but the disease is caused in a single fashion by the single mechanism. So there would be some broad spectrum treatments, and then of course personalized drugs, you see, or personalized treatments for different types of patients.
So now, sir, we are sitting in 2025, February 2025. How do you see pulmonology as a field if we fast forward it 20 years from now? What do you think could be the changes? Maybe AI, of course, that has hit in, the robotics. What is your view on that? How do you see life after 20 years?
I think, of course, the one I think in near future we will be seeing less and less of interventional investigations, you see, and more dependent on biomarkers and on personalized medicine, so that they are non-invasive kind of, and then of course AI-based algorithms for diagnosis. So I'm sure in future we are, again, genetic drugs will be, perhaps the mechanisms will be more precisely defined, you see, and treatments can also be based on some of the genetic origin of the drugs, the diseases, as well as the treatment based on genetic mechanisms, etc. So I think we, in the next 20 years, we will see a lot of difference. There is no doubt about it. Stress will be on early diagnosis, and of course suppressing the disease as early as possible, because some of these changes one would expect. Of course, the AI has changed the scene, and it is not only fast forwarding, it is perhaps sometimes it becomes too fast, you see, that it may not be even possible to predict 20 years nowadays, you see. What was expected to occur in 5 years now occurs in 1 or 2 years itself.
So we'll be watching this after 20 years, and we'll see what came true from this scenario to that scenario. According to this interview, I'm sure we'll be playing. A lot of people will be playing after 20 years.
I'm sure.
Sir, my last question to you, that will be from your wisdom, due to your experience. What is the one piece of advice you want to give to the pulmonologists, young pulmonologists like us, to keep that in mind while growing and practicing? Everybody aspires to become like you. So what do you want to say and to guide us?
Well, I'll say that you should never lose your kind of your decision, your own personalized appreciation of the patient's problem. One should never forget, even as a general doctor or as a pulmonologist as well, that the person who is sitting opposite to you, the patient, you see, he is suffering from some ailments, and it's not the diagnosis which is important for him. So sometimes we lose that perspective, you see, that we treat the disease, treat asthma, treat cancer, etc. But patient may have a lot of other problems, associated problems, especially in India, where you see people are so poor, sometimes cannot afford the treatments, and sometimes cannot even, treatment is not possible to seek treatment itself, you see. So one should try to relieve the sufferings of the patient,
empathetic,
depending on it should be personalized treatment again, you see, rather than the generalized textbook type of treatment prescribed to all patients. So your prescription should be prescription writing is a very nice art which one should learn, you see, and this art depends on the appreciation of the patient's problem. In fact, sometimes back I wrote a book, Medical Encounters, you see. That basically were the stories of few patients and their families, their relatives, you see, who have a very different perspective than the perspective which we adopt. You see. So I think one should not lose that kind of perspective.
I think, sir, you were always ahead of time, thinking and getting ideas like that, writing a book like that, and you have already written one book. I'm author of one of your chapters from the book. So it was a wonderful discussion, sir. I have never talked to you in person for so long, couldn't got the opportunity, but I'm really happy that I'm sharing thoughts with you and getting to know you better. And of course, we gave some important messages to the audience. So thank you so much for coming.
Thank you. In fact, I am in the process of writing Indian history of respiratory medicine from antiquity to future.
Wow.
So I am sure that almost near completion. So I am sure it will interest most of the pulmonary medicine students in the country.
We'll love to read that, sir, and we'll wait for that. Thank you so much, sir. Thank you so much for coming. We'll be seeing you in the next episode. Thank you.
Thank you.